As a clinical lecturer at Addenbrooke Hospital, he developed the interest in the cough, demonstrating cough hypersensitivity caused by the ACE inhibitor. In 1989, Professor Maurice was appointed senior lecturer in Sheffield's developing pulmonary vascular service and the first UK TOF or UK cough clinic. In 1998, he was appointed to the Foundation Chair of Respiratory Medicine in Hull University, Hull York Medical School. The cough clinic has now become the largest centre within Europe, with an international pattern of referral. Unique investigational strategies provide diagnosis and treatment advances, which are incorporated into national and international guideline documents. Professor Maurice has led European Respiratory Society and the British Thoracic Society Task Force on Cough. He has also published over 350 papers on respiratory disease and heads up the Respiratory Clinic Trials Unit, specialising in randomised controls, trials and new treatments for airway diseases. So, welcome, Professor Maurice. Thank you for giving up your time tonight. And we'll get started with the questions. For people who are listening, we're going to start off with, which is probably first and foremost on most people's minds, which is to do with COVID-19. So, first question is, I'm in the highly vulnerable category, and I've been shielding for nearly 12 weeks, even though I didn't receive an official shielding letter. Now my employer is keen to get me back to work. What should I do?
Well, COVID's very interesting. Hello, everybody, to start off with. Yeah, COVID's a very interesting thing. I mean, it's a unique disease. We've never come across it anywhere before. It starts off as just a simple viral infection. And then in the second week, there seems to be a response by the body, which is very aggressive in some people. And that leads to clotting, particularly in the lungs. So it's a unique disease triggered by the virus. But then in the second phase, it's almost certainly an immune response from the individual that is the cause of it. Now, when we started off, we knew nothing about it. So a lot of people were told to shield, but in fact, patients with TOF, patients with cystic fibrosis, patients with other bronchiectasis type diseases, if you've got a bad chest, there isn't very much evidence that you're any more risk than anybody else. And for TOFs, you're mainly a younger age group, and it's old men like me who get it bad, not young people. So really the risk for a TOF person is little worse than anybody else. And if you've not had any lung damage, a lot of TOFs have just the cough, that's not an indication really that you are in a high risk group at all. So the high risk group is quite clearly Black and Asian minorities, patients who are not socially distancing, older people, particularly over 70s, and men. So if you're not in any of those groups, which I presume most of you aren't, then you're not really at very much risk at all. So I wouldn't worry too much about going out of shielding into, if you like, a normal environment, normal post-COVID environment. Obviously, social distancing is very important. You must make sure all the precautions are there. But really, the evidence from other diseases which are similar to TOFs with bad lungs is that there isn't any greater risk of developing a complication. It's those high-risk groups that I've outlined, which are the people who are at danger of developing this second phase of the illness.
I think you've pretty much nearly answered the next question, but I'll go through it anyway. As an adult TOF, I don't have many chest problems. Do I still need to take extra precautions?
No more than the rest of us. So, I mean, be careful social avoidance and wear the mask when appropriate to do so. But otherwise, you're at no more risk than anybody else.
Okay. And for somebody who's returning as a student, have you got any advices for them as returning as students to university in September?
Enjoy yourself.
So there's no precautions they need to take or anything else?
So if they're keeping to the guideline, is it a meter this week or is it 2 meters? I don't know. Anyway, whatever the guidance is for, queuing up in Primark, it should be exactly the same for a university.
I'm a H-type TOF and have a few minor breathing difficulties. I was hospitalized with pneumonia 4 years ago. Should I consider myself vulnerable with regards to COVID-19, or am I more likely to have issues with it more than anyone else?
No, again, the same answer. Your condition is a disorder of the esophagus. The esophagus is not moving very well because of the abnormal connection that you've got or had, and that will cause aspiration pneumonia. So you don't catch a pneumonia like people do with bacteria. You aspirate, that stuff comes up and then goes into the chest or goes into the chest directly. It's called an aspiration pneumonia. They'll give you antibiotics, but they're probably not going to be much good. But you're at no more risk. You don't have a defect of the immune system that, for example, people with leukemia would have, right? And they were the people who really should be shielding. People on chemotherapy drugs, their immune system is disordered. So those are the people who we should have been in with retrospect shielding even more, and particularly the old men in nursing homes. They are the ones who have been dying, not young people. You'll read the occasional report in the newspapers. Obviously, with so many deaths, you'll have one or two, but people are no more risk if you're a TOF than anyone else. What you're at risk of is aspiration, because the esophagus isn't working so well.
My daughter was found to have an extra narrow in trachea, including a blind ending bronchi, where it has started to divide early. She was put on a preventative antibiotics for several years. Given the respiratory nature of COVID-19, would she be classed as vulnerable?
No. The doctors get very worked up about these blind ending little stumps that you get when you're a TOF. They're harmless. So I wouldn't worry about that too much. And she, as I say, she doesn't have a defect of the immune system. She's got a disordered esophagus because the muscle isn't working properly or the nerves aren't working properly. And that's the main problem. It's a completely different pathology when you've got severe COVID-related disease. It's an immune attack by the immune system onto the cells lining the blood vessels. And that's what we've learned over these last 3 months or so.
Okay, thank you. Might a TOF who does not have a TOF cough on a daily basis, but only when they're poorly, but does occasionally aspirate, benefit from prophylactic azithromycin at this time? Might it reduce the coughing if they contracted COVID-19, and are there any possibilities of aspiration?
Well, any TOF is at risk of aspiration, and it will reduce that risk of aspiration. Azithromycin, although it's a very good antibiotic and may actually, according to some reports, have some antiviral activity, probably has no real genuine activity against COVID-19. So what we've got here is an antibiotic which actually works on the movement of the gullet. What it does is acts as a agonist, is the technical term, a stimulator of the hormone motility. And motility is one of the gut hormones that makes the esophagus work properly. So what you're doing by giving azithromycin is giving a powerful stimulant to the motility system to make the gullet moving properly. And that's why it's been shown to reduce the exacerbation rate in cystic fibrosis, for example, in bronchiectasis. And of course, some TOFs who do damage their lungs go on to develop bronchiectasis. So it's a guideline recommended treatment for bronchiectasis and chronic cough. So I would have no worries about going on to azithromycin. It's a very safe drug. Some hint that there might be some deafness in some old people, and the heart problems that people have wrongly accused azithromycin of causing. It can cause palpitations in a very small number of people. I must have given azithromycin to 1,000 patients over my period of time, and I've seen an arrhythmia, irregular heartbeat, twice.
Okay, thank you. Right, on to some cough related questions. When I'm eating, why do I cough? I take 80 milligrams of omeprazole, 300 milligrams of ranitidine and metoclopramide, and I also take Phosphate 2 plus twice a day. I tend to cough up watery matter.
All right. So what happens with the disordered movement of the gullet is stuff comes back. It hasn't actually reached the stomach yet. So it comes back from the gullet back into the throat, and there it irritates the nerves. So this is usually a gas or a mist, and it lands on the nerves here, and the nerves become super sensitive. So most patients with TOF cough, or indeed chronic cough, they will have super sensitive nerves here. So they will be set off by things like strong smells, bleaches, perfumes. And these irritants hit the back of these irritated nerves and the back of the throat, and that's what stimulates the coughing in those particular circumstances. I explain it to the patients like it's like having a burn on the skin. You blow on it and it hurts. The same is happening up here. The nerves up here are very irritated, super sensitive. So the slightest little irritation will set off the coughing about. So there's super sensitivity here, but in the TOF's case, it's often stuff coming up from the esophagus, and it may actually have reached the stomach. But when you've got TOF, you have poor motility of the esophagus. Even if it's been repaired, you will have stuff coming back up and landing up here, causing the hypersensitivity. So the coughing is two components. One is the stuff coming back up, and when it aspirated into the lungs, it can cause lung damage. It's not acid though. So if you go to doctors and say you've got reflux, they'll immediately think acid and put you on high doses, as the questioner have been put on, of omeprazole or ranitidine, right? If you haven't got acid symptoms, it's a waste of time, because the cough is produced by the non-acid component, this mist. So, you know, I would advise people not to take omeprazole or ranitidine unless they really needed it, because the esophagus reacts poorly to blocking the acid. So some people actually are made worse and increase the amount of aspiration they get, because they now no longer got the acid signal when they are aspirating. So if you look at studies in the general population, people who are on lansoprazole, omeprazole, that sort of drug, they actually have an increased incidence of aspiration pneumonia, because the acid signal warning them to cough it out is gone. So unless you've got rampant heartburn or severe indigestion, I think that these drugs are probably doing more harm than good.
Thank you for that. What can we do when we present ourselves to A&E after an aspiration and get told, well, your numbers are good, but you know actually you feel really unwell?
Well, that's true of a lot of life. I always believe the patient. I mean, if the patient says they're unwell, they're usually unwell. But I'm afraid you do come across doctors who think that they know best because the numbers are okay. So a good example in TOF world is that you'll get a breathlessness attack, and okay, that's the same phenomenon as the cough. The nerves here are also cause breathless attacks. So people will come into A&E really very breathless, but their oximetry is normal. So the doctor says there's nothing wrong with you, but in fact there is something wrong with you. You've got oversensitive nerves which are producing this profound breathlessness that people can get. So, you know, it's ignorant doctors again who are to blame for this. They think that all breathlessness is due to low oxygen, and in fact low oxygen hardly makes you breathless at all, with rare exceptions. So it's not a good indicator of how you feel. How you feel is how you are. And if you're breathless, it's probably due to oversensitive nerves rather than a massive amount of damage being caused. But the sensation is genuine.
Okay, thank you. The next question actually is from somebody from Germany. When I get flu, I have a coughing fits and to the point of throwing up. I also have a fundoplication, so throwing up is concerning me too. Do you have any suggestions as far as the cough suppressants are concerned? Here in Germany, they prescribe me morphine drops to help me sleep, but sometimes they're not taking effect.
Yeah. Okay, I'll deal with the morphine first of all. Morphine is a very good drug for people with cough, but it only works in about a third of people. So either you're sensitive to the morphine and it works, or you're not. And morphine, we showed in a randomized control trial, is very good at suppressing excessive coughing in some people, but it is only some people. So either you're a morphine responder or you're not. So if you've taken morphine at low dose, it only needs to be low dose. If you've taken low dose morphine and it's had no effect on your cough, you're a non-responder and morphine will not help. And you can't go up the dose with this, unlike pain where you can increase the dose. In this case, what you need to do is say, actually, I'm a non-responder. I'm going to look for something else to modify the cough. If you've had a fundoplication, fundoplication stops acid reflux brilliantly, but it doesn't stop the gas coming up. So a lot of people who've had so if you look at my experience in people with chronic cough, and we must have done 100 fundoplications at least on these people. If you look at that, about 2/3 of them get better and 1/3 has no effect at all. Because no matter how tight you make the fundoplication hole, right, you've got to allow food to go through. And this, of course, will allow the gas to come back up. So if you understand that it's a gaseous mist coming up and irritating the nerves, your fundoplication will have stopped any acid symptoms, but it will not necessarily have stopped the cough.
Okay. And a second question from the same, I presume from the same person in Germany. Can you recommend anybody they could go and see about their cough in Germany? Secondly, I'll add another one onto that. How do people in the UK get themselves referred to you?
Well, why do you want to see me? I'm quite happy to talk to people, and you know, there is little point dragging yourself up to Hull, even if it's a lovely city of Hull, to come and see me. But you know, I do correspond with people on the internet, and if they've got specific problems that they want to deal with. So, for example, the gentleman from Germany who's had the fundoplication, what I would advise him to do is to get high-resolution esophageal manometry. This is the test that tells you the movement of the gullet. Right? It's a tube down, and what it does is measure the pressures in the esophagus and in the stomach. So you're able to tell where the problem is, and different problems have different solutions. So quite a few TOFs, particularly those who've had a gastric pull-up, all right, they get a big dilated sac above the diaphragm where the valve normally sits. So this big dilated sac sits there with rotting food in it, basically, and that's the stuff that's coming back up. And in that particular case, what you can do is you can do put what's called a bougie, a device in to open up the restriction. But the only way to discover that is either a barium meal examination if it's very large, or high-resolution esophageal manometry, which is the other test that I mentioned. So it's no good having a camera down, doesn't work.
Okay, thank you for that. Just before I get on to the next question, because it's about erythromycin, one person's put in the chat room, I'm allergic to erythromycin. Is there an alternative?
Is it erythromycin or azithromycin?
Sorry.
Azithromycin. Well, you could try erythromycin. It's not as effective. The great thing about azithromycin, it has a very long half-life in the body, so it builds up. So you won't reach peak levels until about 5 or 6 days. So you need that boost, if you like, in blood levels to enable it to work. Erythromycin has a much shorter half-life, so you would have to take it twice a day, and 250 twice a day is, probably works a bit. Try erythromycin, but there are other motility agents or other agents depending on where the problem is. So one of your previous correspondents mentioned metoclopramide. That's a drug I use a lot because that tightens the valve at the lower esophageal sphincter. So it stops stuff coming back up the stomach if you have a functioning lower esophageal sphincter. Domperidone is another drug that I use quite a lot. And there's another drug called baclofen, which also tightens the valve up. But the best evidence base is by far azithromycin, and an alternative for that is erythromycin. But it's got a shorter half-life, and you'll have to take it twice a day.
Okay. One on now, azithromycin. I'll get the right one. I take azithromycin daily for motility reasons and found it very helpful. However, I'm struggling with digestive issues in the bowels, such as stomach pains, constipation, and occasional diarrhea. I wonder if there is anything I can do to help with the side effects.
Well, it is a problem. That is the main side effect of this drug, because it works on the movement of the gut. So people do tend to get stomach cramps, and indeed it is intolerable in some people. I mean, it's made worse by fundoplication if that's happened, and then it's trapped gas because the fundoplication traps the gas, and you end up with stomach bloat. You fart all the time, so it can be a big problem. But often people with disordered movement in the esophagus, they also have disordered movement in the gut. So irritable bowel syndrome, if you look at chronic cough patients, irritable bowel syndrome is the commonest associated disease. So you've got a disorder then of the whole of the gut movement. But azithromycin is notorious for causing this tummy gripes that people get. So it's a great drug, but it's not perfect.
Okay, thanks for that. Can you say which medication you'd recommend for me as an adult TOF to help me with my TOF cough?
Well, azithromycin, because your cough is due to the disordered movement of your esophagus. So that is the mainstay, I would say, of treatment, with a very good evidence base behind it now. The other drugs that I mentioned, metoclopramide, domperidone, baclofen, they can be tried, but you really want to know what's wrong with the see, TOFs are not just one group. You've got people with this dilated esophagus that I've told you about, or dilated stomach that sits in the chest. And then you've got other people who had a surgical repair, and the problem is the gap between the top bit and the bottom bit where the surgery has taken place, there's scarring. And so the movement is restricted in that area. So the esophagus doesn't work in that one particular area. And then there are other people who have problems with the valve at the bottom, particularly if you've had some sort of pull-through operation or colonic transposition. That's a nightmare, because the colon often, as the time goes by, expands to have this collection of stuff sitting there in your chest. And when you lie down, you start coughing. So it's an individual thing. If you wanted to investigate it, the simplest thing is to ask for a barium swallow. So if you do a barium swallow test, which is fairly risk-free and available in most hospitals, then you'll be able to get a picture of what's actually going wrong with the esophagus there. But regarding treatment, tomorrow I am in a telephone conference with the makers of the first of a new generation of anti-cough drugs, which seem to work very well indeed. It's the first new drugs for cough in 40 years. And this is the results of their big study, which they're going to get a license for the drug from. So the drug should be out next year. It's called gefapixant. And this, I think, will get rid of all of the irritation here, because it works on the nerves to dampen down the excessive irritation that people with TOF cough get. So I think in 2 or 3 years, because there's no less than 4 drugs now in late stages of development. So in a year or two's time, we will be able to recommend a drug which will get rid of that hypersensitivity, get rid of that irritation. And as far as I did an experiment, a controlled trial, showing that it doesn't get rid of the irritation which prevents aspiration, which is great news. So you'll be able to get rid of the excessive coughing, but retain the ability to cough it out if it goes down the wrong way.
Okay, thanks for that. Throughout adult life, should patients who have had a gastric transposition be monitored for vitamin and mineral deficiencies, or be prescribed supplements?
That's a good question. It depends on the operation, because, as I say, each TOF is an individual, and the main absorbing areas are actually the small bowel rather than the stomach. So the stomach is an organ which grinds up the food and does do some digestion, but the major part of digestion is in the small bowel. So there are reasons why perhaps you might have to check the vitamins, but I wouldn't routinely myself prescribe extra vitamins for a TOF unless you were actually having dietary problems and were exceedingly thin, for example. That would be the indication to look at that in greater depth. But whatever the operation, it shouldn't really affect the main vitamin and food absorbing parts of the body, which is the small bowel.
Okay, thanks. What are the side effects from taking PPIs long term? Do I need to take supplements like magnesium alongside PPIs? And if so, what sort of dose would you recommend?
Don't take the 8 PPIs is what I would recommend.
Nice and easy.
Well, I mean, you know, unless you've got rampant heartburn, you don't need to take them, in my view. Gastroenterologists are frightened that you'll develop irritation of the esophagus and a thing called Barrett's esophagus, which is a theoretical risk. And as I say, the cough itself and the hypersensitivity are caused by the non-acid component. So unless you have symptoms, I would not recommend PPIs.
Okay. Is it beneficial to use a 3-ball Lung Incentive Spirometer or Spirometer?
I'm sorry, Duncan.
He said, is it beneficial to purchase and use a 3-ball Lung Incentive Spirometer?
Well, I don't think it's a spirometer. It sounds more like one of these devices that you blow into to increase lung capacity. But the idea behind that is because of COPD. When in COPD, chronic obstructive pulmonary disease that the smokers get, what happens is the lung tissue is eaten away by the cigarette smoke and the airways tend to collapse. So by pushing on the end of this, you open the airways up and allow the mucus out. So unless you've got quite gross lung damage from bronchiectasis caused by aspiration, then I wouldn't have thought that that would be very useful.
Okay. Another one. I am 17 and was recently diagnosed with a H-type TOF. I have VACTERL. What should I expect post-op? Is it likely that I will develop a TOF cough after my repair, or are there ways of reducing the chance of developing it?
Well, we don't know until you've had it done. You don't know. If the surgeon has to cut the vagus nerve, which is the main nerve in the chest, it supplies all of the organs of the chest and the throat, including the heart and the gullet, goes into the stomach even. So this nerve runs in between. If that's the esophagus and that's the trachea, it runs in the gutter between. And of course, that's where the H part of the TOF is. So if the surgeon's able to get it in there and repair without damaging the nerve, then you probably won't. But if they do have to damage the nerve in order to repair the thing, you may be left with a TOF cough because of the lack of innervation which drives the movement of the esophagus. So until you're really in the hands of the surgeon for that one, and good luck.
Okay. I'd like to know what the general experience for those who have a colonic interposition is like. Does it have an impact on quality of life, energy levels, and specifically, does it affect fertility?
It shouldn't affect fertility. It is not a perfect operation, but it's the only one that can be done in certain types of TOF. And you've got to balance up, being better, if you like, and having an intact upper tube, even if it's the wrong tube, if you see what I mean, against continuing the illness. So I think on balance that you've just got to accept what you've got, and it depends on what happens to that individual. So I have seen patients with grossly dilated transpositions, grossly dilated stomachs, which come on over the years. So that increases the risk of aspiration, because all you've got to do is to protect your airway is the vocal cords here. So if they're able to work properly and prevent aspiration, then even that should be okay. But of all of the operations, this is the least satisfactory, but it's the necessary one in certain circumstances. The major problem that I've come across is that tightening at the bottom of the sac, where there is not insufficient outflow. So it's called outflow obstruction. So you may get this dilation in the chest and then go down to a narrowing point here, and then the surgeon can dilate that up under endoscopy and make the hole bigger to allow the stuff out of the stomach, which is in the chest, or the colon, which is in the chest. And so I've got about 3 people on my books who regularly undergo this procedure.
Okay, thank you for that. My son is an adult TOF aged 35. He has no follow-up since he was 14. My concern is he had silent reflux as a child, and I'm worried about Barrett's esophagus. We live in Ireland, and he's asked his GP about arranging a scope, but was told it was unnecessary.
Well, Barrett's esophagus, as I've described before, is a change in the lining of the esophagus from one cell type to another cell type, and it's reputed to be a pre-malignant change. But the evidence is that it's tiny increase, but the gastroenterologists are very keen on it, so they tend to want to do a scope. I wouldn't myself worry about it too much. If he's not having any trouble, I mean, the main problem for TOFs, as far as I can see, is aspiration. The risk of Barrett's esophagus is fairly minor, and I expect the gastroenterologists have already put him on PPIs if they're worried about that, or mentioned that as a possibility. Okay, there may be some evidence that there is a diminution of Barrett's esophagus when you got rid of the acid, but really the problem with TOFs is non-acid reflux, not acid reflux. So I wouldn't worry too much, is my answer.
Okay. And the next one's about alcohol, which sort of comes back to perhaps our university students, and you said go and have a good time. Please, can you explain how gastric transposition affects alcohol tolerance? Because it's important for patients and their relatives to have this information.
Yeah, well, the blood has to go through the liver to from the guts. So what you've got is a situation where the stomach has been put in the wrong place, And so it doesn't obey the usual mechanics of getting the food through into the small intestine or the alcohol through into the small intestine. So it's not an easy thing to predict in any individual, but there is something called the dumping syndrome, where you have a drink or eat a bit, and then it causes an excessive absorption at one go into the circulation, and it causes the blood sugar to rise, and you get a lot of symptoms from that, and the alcohol will also suddenly increase. So this dumping syndrome that you get can be quite upsetting, but it's again an individual thing. I cannot, in front of all of this audience, say, you know, you and that individual will be at risk of that, because it all depends on the anatomy of your particular problem and how they've fixed it.
Okay. And just a general one about TOFs. How can adult TOFs better manage their respiratory issues?
Well, you need to have a sympathetic doctor, I think, because a lot of doctors will say you've got a chest infection, and in fact you've aspirated. So the doctor puts the stethoscope on, he hears the rattling and assumes that it is a chest infection. And so people will be given a large amount of unnecessary antibiotics because of this chest infection. But it isn't an infection, it's an aspiration. If you come down with a runny nose and then a couple of days later you start coughing a lot, that's probably a respiratory tract infection, but it's almost invariably a virus. So giving antibiotics in that situation is again rather bizarre. But if people have got damaged lungs, they can then harbor pathogenic bacteria in the lungs. So there is a particular bug called Pseudomonas, and Pseudomonas is very typical of people who have bronchiectasis. So if you've been aspirating over your life and you've dilated tubes, which is bronchiectasis, the stuff collects there, and the Pseudomonas is typically a very difficult bug to get rid of. If you've developed it for the first time, and what you would do if you have purulent sputum, nasty green phlegm, then the doctor should send that off to the laboratory to look for the bugs. Don't just take antibiotics, because if it's Pseudomonas, it doesn't respond to the usual antibiotics that the doctor will give. So if you're trying to diagnose yourself as having a chronic chest problem with green phlegm, you must get repeated sputum samples sent off to the lab to find out what the bug is, if it is a bug. Sometimes it isn't, but the bug to watch out for is this Pseudomonas, because there's only one oral antibiotic to which it responds. And we have to give some people intravenous antibiotics to get rid of that bug or get its head down. When you've got bad bronchiectasis, you're never going to clear it properly, but you can treat it and get over the exacerbations. But the doctor needs to know that you've got a Pseudomonas infection.
Okay. Right. I'm going to now jump to the chat room because there's quite a few questions in there. The first one is, I had a Nissen Fundoplication done at 4 months of age. I'm now 34. Food's been getting stuck for the past 3 years. Would undoing this procedure be better, or putting a half wrap be better?
Half wrap's no better than a full wrap. Food's been sticking where? That's the question, really. And you won't know, because all of the sensation feels about here. So all of the sensation from all of the guts feels about here. So I got a chicken bone out of someone's lung down here, and he said, "It's just here, doctor." So it's a poor localization of the sensation. You can't tell where the food is sticking. So in that particular case, I would get myself a barium meal or barium swallow, like I suggested, and see where the hold-up is. And if they've got high-resolution esophageal manometry, that would be the test that I would do next to see exactly where the physiological problem is. See, it could be that the fundoplication has now slipped, because it can slip upwards, and then it becomes ineffective. or it could be that there is a bit of stenosis there from scarring, or it could be that the esophagus itself is not working very well. So there's a number of possibilities there, and you need to have, I would suggest the simplest thing to do is to get a barium swallow examination and try and see where the problem is.
This next question is from the same person again. Is there any reason why I would have left flank pain?
Something wrong with the left flank? I can't think of a reason, not from a TOF point of view. Yeah.
Okay.
I think you've probably got something else wrong.
Okay. And their final question is: as I've gotten older, I've noticed I've started to slump a lot. Less in pain in my chest area by slumping. Is there anything I should be doing or looking at for this?
Well, it's part of getting old, isn't it? Slumping a bit. I've been worried about my slumping. I don't think there's anything you can do about it. Posture is an important part, and when we can get back into the gym, I would try that rather than anything medical on that front. You don't want surgeons operating on you on your back. It's a path to mayhem, in my experience. So, yeah, these things happen as you get older.
Okay. My son is 34, H-type TOF. He has had no problems since he was small when he had silent reflux. Would you recommend he has a scope to check if there is any damage caused to the esophagus? He gets occasional heartburn, but is not on any medication.
Yeah, it was the same answer that I gave to the Irish person.
Yeah.
It's probably nothing to worry about, and you know, I don't do tests unless I want to know the answer.
Okay. Since my fundoplication 4 years ago, I've developed a foamy reflux. What would cause this?
Well, it's being trapped above the fundoplication, so it's collecting in the whatever part of the esophagus or stomach or whatever it is there, and coming back up. It's probably a mixture of saliva and any liquid that you've drunk. Sits there in a pool above the fundoplication.
Okay, just having a quick scan to see if there's any. Oh, here you go. During after I eat, I get a thick mucus in my throat. What is it and how can I help it? H20, a VACTERL.
Yeah, well, the mucus is the stuff that's come up and landed in the throat or in the upper esophagus here, and it irritates it, and it irritates the nerves, but it also irritates the mucus glands, and so the mucus glands then start producing this thin, usually white stuff that is coughed up or vomited up, but it's usually coughing, and it's a consequence of stuff irritating the airways, leading to mucus hypersecretion.
Okay. Do you know of any specialists in Scotland who deal with colon interposition surgery?
Well, it would be a surgeon, wouldn't it? Not a physician, if you're talking about the surgery. If you're talking about post-surgical care, then the best person is a guy called James Chalmers in Scotland, in Dundee. And James is a world authority on bronchiectasis, and he will, I'm sure, see people with TOFs. You can always give me a ring because we're good mates.
Okay. Another one. My daughter has just had a thyroidectomy operation and now seems to have a TOF cough back. Is this normal because it's causing more pain for her?
Well, as I said, the nerve runs along here, so sometimes on the thyroidectomy they can nick the nerve if they've taken most of the thyroid out. The vagus nerve supplies the thyroid and the larynx up here, so there's branches. I mean, it even goes into the ear, so some people get a cough when they put their finger in their ear. That's the same nerve which has been irritated. So this nerve, it's called vagus because it's the same root as vagrant. It wanders around the body to different organs. And what happens when you get the TOF cough is that you get this hypersensitivity, and the whole nerve is hypersensitive. So it could be that something has irritated that nerve. The superior laryngeal nerve comes along here, right by the thyroid. So it's a genuine observation, I believe, but as to what you would want to do about it, I don't know. It's likely that there is an element of this gas is non-acid reflux. So, you know, you might want to try the azithromycin if they haven't tried it already.
Okay, I'm sure I know the answer to this next question, but I'll ask it anyway. Is smoking much more harmful to TOFs compared to the general population?
I wouldn't say it was more harmful. Smoking is harmful, period. So you know, if you look at the risk factors for remediable risk factors, direct cigarette smoking is an extremely dangerous thing to do. In comparison with COVID, it's probably killing more people at this moment than COVID is worldwide. So it's a major health issue. So, and I'm not talking about passive smoking here necessarily, but active smoking. Anybody who cares about their health at all should not smoke, period. And I don't think it's, you know, a matter of this is worse for you. It's bad for everybody.
Okay. I'm unable to be sick or bring up any mucus. Is this due to dysmotility, sorry?
Not usually. I mean, after you've had a fundoplication, that's where they wrap the top of the stomach around the bottom of the esophagus to prevent reflux. If you've had a fundoplication, then you can't be sick afterwards usually, although some people manage it, but in general you can't be sick. It's perhaps that you've got a stenosis there, but if you want to check that out, again, the barium meal test that I mentioned before would be a way of visualizing what's actually wrong with the gut. It's not very good on the motility. The motility test, if you've got a relatively normal tube, is the high-resolution esophageal manometry. And an endoscopy, a telescope test, is pretty useless. So those are the two tests that I would advocate in that particular circumstance.
Okay. Would you ever do an endoscopy just to check the esophagus to see if it has grown or stretched with you? Somebody asking for their 18-year-old son as he's changed to adult care and they're thinking about having it done.
It's not a very useful test. The barium test is the best one to see the diameter of the esophagus or the stomach or whatever's there. Very rarely do I recommend someone going for an endoscopy.
Okay. I'm 53. I'm experiencing more food becoming stuck, especially bread. Will this deteriorate as I get older? I have severe dysmotility.
Well, I haven't got my crystal ball with me, but I would guess yes. It's due to dysmotility, particularly bread. I don't know why. If anybody can explain to me why bread is a particular problem, I'd love to know, because it's true of both TOF cough and ordinary chronic cough. And it's the dysmotility almost certainly. In fact, what we have is bits of bread soaked in barium. So when people can swallow that, you can see the barium sticking in the throat there with on X-ray. So I've got some good videos of that. So yes, you're absolutely right. It's probably increased dysmotility. And as I've said several times, the best treatment at the moment is azithromycin.
Right. My 14-year-old daughter has tracheomalacia and complains of a sore chest, breathlessness during exercise. We have been told that the worst that could happen should she push herself during exercise is fainting due to insufficient oxygen. Do you agree with this, or are there other adverse effects?
No, it's rubbish. If you put an oximeter on her when she's exercising, I bet her oxygen saturation doesn't fall at all. This exercise-induced symptoms are often due to reflux. So when you're exercising, you are refluxing a lot, and a lot of elite athletes do this, so that people will have the symptoms of chest tightness, breathlessness I mentioned earlier on, and there will be no effect on the oxygen saturation at all. Unless she's got severe lung damage, which I presume she hasn't, this is a symptom that people get because of the hypersensitive nerves. And, exercise is good for you, but it does induce reflux. So exercise which doesn't induce so much reflux is perhaps the best idea. Swimming, for example, but strenuous running, for example, very many ordinary people get reflux during these episodes. It's a part of the syndrome, but the symptoms are mainly due to hypersensitive nerves, not any lack of oxygen. I mean, you can buy these oximeters now, and I bet you it doesn't go down an iota when she exercises.
Okay. Are there any complications after H-type TOF repair is done when they're not an infant that people need to be aware of?
Well, I'm not a surgeon. I mean, the main one in my vocabulary would be that the nerve has been damaged when they've done the repair. So if you damage the vagus nerve, it has lots of consequences both in the upper and lower gut. That nerve is very important in moving the guts around. And people who've had in the olden days, when I was a medical student, we used to do a thing called a vagotomy, where you would chop the vagus nerve to prevent acid secretion, too much acid secretion. And people had an enormous number of problems because now the stomach didn't move properly. So you would get delayed gastric emptying, you'd get bloating, dumping syndrome is another thing you would get. So the problem there is due to the nerve generally being damaged. But as I say, the nerve runs right in between the esophagus and the trachea, and it's a very difficult job for the surgeon to unpick everything.
Okay, next one's an interesting one. Somebody's heard that Botox injections in the esophagus help with motility. What are your thoughts?
We've tried that for our chronic coughers without much success. I can't recall a good paper showing that works. What it will do is prevent the muscle contracting. So if you're suffering mainly from esophageal spasm, that might be a possibility. But as I say, I've tried it on several patients with the chronic cough, and it hasn't actually helped them very much. These are people with poor opening of the lower esophageal sphincter, and the food gets trapped in the esophagus. Yeah, people are individuals. It might work, but there is no good scientific evidence that it works. And my experience is that it hasn't worked.
Okay, I've never heard of that one, so there's a new one on me. Somebody's had a manometers test and was told that they have no motility. They said that there was nothing that they could do, therefore, should they be going to the GP and requesting to put on Azithromycin?
Yes.
Nice short
it shows the ignorance of the doctors, again.
Does a fundoplication have shelf life? My son underwent a Watson's fundoplication, age 15. His adult consultant states that he cannot see any evidence of it.
Well, I don't know on what basis the current doctor is saying that. Fundoplications can slip, they can come undone. I don't know the Watson very well, but the normal one, which is called a toupee, is a 360 wrap around, and even then they can come undone or move. The way to do that is, again, the high resolution esophageal manometry test, and if the manometry test shows no tightening at where the esophagus gastric junction should be, then that indicates that the fundoplication is no longer effective. What's actually happened to it, I don't know.
Okay. And then somebody was born in 1975, their operation to their esophagus, and left one of their lungs unable to drain correctly. Would that count as sufficiently damaged to put them in the high risk category for contracting COVID?
As I've said before, I don't think there's any evidence that people like this are any more at high risk than the rest of us. I mean, if 75, so that makes 30, 40.
About 45.
Yeah, about 45. Well, you're in a low risk group.
Okay, and if somebody started coughing and they were a TOF, would you recommend that they go and get themselves tested quicker than anybody else, or the same as everybody else?
Yeah, you're right. You know, your immune system's normal. You've got a disease. If you've got bad lungs, then you may think of yourself greater risk. And indeed, we did think of this at the beginning of the epidemic, but the evidence from other diseases like bronchiectasis, like cystic fibrosis, is that these people are no greater risk than the general population. Risk factors are being a man and being old.
Okay. Just one more final question just popped in. If someone has Barrett's, would azithromycin be preferable to PPIs?
That's a good question. Well, the gastroenterologists are very hooked on the idea that it is acid which causes the Barrett's esophagus. I don't know myself that that is true. There is an association with acid reflux and Barrett's esophagus. And if the person is having acid symptoms, heartburn, etc., then probably they should be on the PPI. But as I said earlier on, the PPI blanket use in TOFs is probably overreaction and may actually do harm. If you're talking azithromycin, it works in a completely different way than PPIs. PPIs don't block reflux, they block acid. So you reflux just as much on a PPI as you do off a PPI. What it does is stop the acid coming up so you don't feel the acid symptoms. The real question is, does the acid cause Barrett's, or is it the reflux that causes the Barrett's? And I don't think that's very clearly defined, even by the gastroenterologists. But, you know, many of them think that PPIs work on reflux, and it doesn't. It just changes the composition of reflux.
Okay. Professor Maries, thank you for your time tonight. It's been very knowledgeable for a lot of us, and obviously we've got through a lot of questions tonight. So we very much appreciate you giving up your evening and answering all our questions. For everybody who's listening, Anna will be sending out a questionnaire, and obviously if we get a lot more questions coming back to the office, hopefully at some point, perhaps in the future, we can perhaps do another session like this where we can answer a lot more questions for our members.
Be very happy to, Duncan. Been a pleasure.
All right.
Cheers now, everybody.
Thank you for your time. Thank you.
Bye.